Good afternoon, and thank you for joining today's webinar. This is a webinar that's been jointly sponsored by the AASLD and the AST on COVID-19 in the liver, chronic liver disease, and transplant. My name is Elizabeth Verna, and I'm from Columbia University in New York, and I'm pleased to be one of your moderators for today's webinar. This webinar is being recorded and will be made available on the AASLD website and in Liver Learning. You're encouraged to submit questions for the panel using the Q&A box at the top of your screen and not through the chat function. We will answer as many questions as time permits during the webinar in the Q&A box, and we'll select some of these questions to be asked of our panelists after our speaker presentations. As I mentioned, I'm Elizabeth Verna from Columbia University and will be moderating this event along with Dr. Emily Blumberg, who is the immediate past president of the AST and a world-renowned leader in transplant infectious diseases from the University of Pennsylvania. I'm honored to be joined by a distinguished panel of speakers, including Sid Barrett from UNC Chapel Hill, Olivia Cates from University of Washington, and we also have an outstanding panel of thought leaders in hepatology, pediatrics, transplant surgery, and transplant ID from around the country who will be taking questions at the conclusion of the presentations. Finally, I'd like to acknowledge all of the members of the AASLD work group who continue to work hard to update our COVID-19 resources. After brief introductory remarks, our agenda for today includes an overview of updates of the Clinical Insights document from Orrin Fix, a talk by Sid Barrett on emerging data on outcomes of COVID-19 in patients with chronic liver disease and cirrhosis, a talk from Olivia Cates on what we know about COVID-19 in liver transplant recipients, and this will be followed by a lively panel discussion about the management of transplant candidates and recipients in the midst of this ongoing pandemic. As we are all aware, the global impact of COVID-19 continues to evolve. Now with almost 10 million confirmed diagnoses worldwide. While there are areas of the world in which the cases have fallen significantly over the last several weeks or months, there are also clearly areas of the world in which the peak incidence has not yet been reached. This has had a profound impact on solid organ transplant candidates and recipients around the world. In New York State alone, over 1,000 transplant recipients with confirmed infection have been reported in a statewide registry of 13 transplant hospitals, including over 130 liver transplant recipients. Overall, about 20% of these patients have died. And while in the last month there's been a clear decline in the number of new cases per week in New York State among solid organ transplant recipients, it's clear that the practice of liver transplantation was dramatically impacted over the last several months in New York and around the country. Across the US, all aspects of liver transplantation were clearly impacted, including a decline in new listings, a decrease in the total number of organs that were procured, and the total number of transplants that were performed. This change was even more dramatic among the hyper-endemic regions like the Northeast of the United States, which of course includes New York and New York City. However, it is also clear that there was very significant heterogeneity in the approaches taken in different regions and even in different centers. While this was likely based in large part on local disease prevalence, even within a region or a particular city, there's been a wide range in the changes in transplant volumes, with some programs inactivating large portions of their wait lists and others doing even more transplants than would be expected based upon historical data or the local availability of donors. We are all now facing the reality that there is likely going to be ongoing transmission of SARS-CoV-2 for some time. And as states are going through phases of reentry and human mobility has increased, there has been a perhaps predictable rise in the number of new cases reported throughout the US, as well as ongoing spread through all 50 states. It is in this context that we are presenting this webinar to discuss what we have learned about caring for liver transplant candidates and recipients in this new world with COVID around us. Ensuring the best outcomes for our patients in this new environment will clearly be a multidisciplinary effort. And for this reason, it has been a great honor to partner with the AST to develop this webinar. So without further ado, I'd like to introduce our first speaker, Orrin Fix, from Swedish Medical Center, who will go over this week's updates to the COVID expert panel consensus document.
Thank you very much, Bessie. Next slide, please. So for those of you who are new to the AASLD's resources on COVID-19, we've been putting out this expert panel consensus statement with various updates since March 23rd when it was first published online. It is also published in print in Hepatology, and we've just posted our latest update this morning on the link that you can see there on the page, aasld.org/COVID-19. You can see from the table of contents that we cover quite a lot of ground. And I encourage you to go to that website and download it. It's available for free. Next slide, please. So just to review some of the major changes since our last update on June 4th, one of the things that we continue to struggle with is trying to reflect the changes that are occurring across the country, ramping up routine and in-person clinical care procedures and also clinical research. This has been difficult to advise across the board because we know that everybody in the country as well as across the world are in different phases of the pandemic. And also we know that while people are trying to get back to more normal routines, we're starting to see a rise in many areas in infections. And so we need to be prepared to potentially dial back a little bit and go back to what we were doing at the beginning of the pandemic if necessary based on local prevalence. So the underlying message to all of our recommendations regarding how to handle patient care really is about being aware of your local prevalence of SARS-CoV-2 and also being prepared to go back to more intense mitigation strategies as necessary. The other thing that we wanted to identify in this update is that we've identified a few preprint articles as basis for some of our recommendations. And in the beginning of the pandemic, this was appropriate because things were happening very quickly. People wanted to get data up online as quick as possible. But we thought it was necessary at this point to clearly identify what is not yet peer-reviewed and try to work toward more peer-reviewed sources. Next slide, please. So I think it's fairly clear that having cirrhosis and COVID-19 is a bad combination, and we added a retrospective Italian study showing a high mortality rate in hospitalized patients with cirrhosis and COVID-19. Next slide. And this adds to accumulating evidence that patients with cirrhosis and COVID-19 have a higher risk of death compared to patients with COVID-19 alone. But we're also seeing more data that perhaps cirrhosis alone without COVID-19 is just as bad. And there's some data that inpatient mortality in patients with cirrhosis and COVID-19 may be similar to the mortality of patients with cirrhosis alone and without COVID-19. And just the cause of death may be different, whether it's decompensated liver failure or pneumonia and ARDS. Next slide, please. We've added some studies that support what we've speculated from the beginning, and that is that perhaps immunosuppression in the face of COVID-19 is not necessarily bad and may possibly be protective. There's a retrospective Italian report of 10 patients with autoimmune hepatitis on immunosuppression and with COVID-19 that suggests that the course of COVID-19 may be similar to non-immunosuppressed patients. And the authors suggest that preemptive reduction in immunosuppression during COVID-19 can be potentially harmful. And this is something that we've been recommending since the beginning, that we should not be preemptively changing immunosuppression in our autoimmune patients or in our post-transplant patients. And there's also single center and more registry data of liver transplant recipients with COVID-19, and I'm not going to steal the thunder of our speakers who will be addressing that during this webinar. Next slide, please. We've added the very highly publicized data on dexamethasone, which appears to be good, but this is in preprint form currently, not peer-reviewed. But the data is very promising from the recovery trial that there may be a significant mortality benefit from dexamethasone in patients receiving invasive mechanical ventilation or oxygen without invasive mechanical ventilation. But be aware that there was no benefit in this study and possibly harm from dexamethasone in patients that did not require respiratory support. Next slide, please. And then finally, we've removed a lot of the information that we had on our update about hydroxychloroquine now that the FDA has revoked the emergency use authorization for both chloroquine and hydroxychloroquine after they determined that these are unlikely to be effective in treating COVID-19, and actually the cardiac effects may outweigh any potential benefit. Next slide, please. So again, I want to encourage you to go to the AASLD COVID-19 resources webpage where you can download the latest update. And this is also where you can get any other resources related to COVID-19 in the liver from the AASLD, including recordings of this webinar and past webinars. Thank you very much.
So next I'd like to introduce Dr. Barrett from UNC, who's going to give us a talk about the emerging data on the impact of COVID-19 in advanced liver disease.
Thank you very much for the kind invitation to speak. So this talk will be on the emerging data on the impact of COVID-19 in advanced liver disease. Next slide. I have no relevant conflicts. Next slide. So for today's talk, I'd like to discuss both the direct and indirect effects of COVID-19 on the liver, the impact of COVID-19 on patients with chronic liver disease, and some parting thoughts on how we manage our patients and where we might go from here. Next slide. So liver damage is common, and we've seen it with the previous coronavirus infections. The SARS-CoV infection from the 90s and the early 2000s, and the MERS-CoV infection as well too. SARS-CoV-2 binds to cells through the angiotensin converting enzyme 2, or ACE2. ACE2 occurs in liver and biliary epithelial cells, thus the liver is a target for infection. Data regarding the SARS-CoV-2 infection, henceforth referred to as COVID-19, is conflicting and suggests that liver damage may occur by a direct cytopathogenic effect or due to immune-mediated inflammatory response. And this is why some of the data suggest that dexamethasone and other immunosuppression may be helpful. We do know that liver damage is common as measured by liver enzyme elevations. And in a summary of 12 reports of COVID-19 from China, they describe abnormal liver enzymes in up to 60% of patients with a mixed impact on outcomes. Next slide. So we see COVID-19 infections with elevated liver enzymes in up to half of patients in prior literature, and more recent reports suggest that it may even be higher. In 60 consecutive patients who were admitted to MASH General, liver enzyme elevations were quite common. What the authors saw were that cholestatic enzyme elevations were actually rare. Elevations in bilirubin and alkaline phosphatase were not seen nearly as commonly as elevations in the transaminases, the AST and the ALT. And what they saw here was a predominance of the AST. This was common. Interestingly, this AST elevation was not correlated with any muscle injury or CK elevations, nor was the AST elevation directly associated with any inflammatory markers. So this appears to reflect true hepatic injury. As you can see in the graphs on the right, the AST was higher than the ALT in patients throughout their hospitalization, and the AST was significantly elevated independent of creatinine kinase elevations. It was difficult to predict in whom these elevations occur, as there were no clear demographic or prevalent comorbidities that were associated with liver injury. Next slide. We can also see coronavirus have an indirect impact on the liver. And this is because of confounding, because these patients are so sick. Many of our patients are critically ill and can suffer from ischemic liver injury. They receive a variety of medications, including antibiotics and antiviral medications. Also, many of these patients come into the hospital with abnormal liver enzymes on day one. So could some of these abnormal liver enzymes reflect prevalent chronic liver disease? Perhaps not. Of the data that are out there, the prevalence of chronic liver disease is actually lower than we might expect. Abnormal LFTs too can have an indirect effect on our patients because it may limit their enrollment in clinical trials for novel COVID therapies. In terms of the potential for drug-induced liver injury in patients suffering from COVID-19, we do see that the odds for liver injury increase with a variety of different medications, especially antiviral therapies. Next slide. In terms of the impact of COVID-19 on patients with chronic liver disease, there's been limited information, but this has evolved very quickly over the last several weeks. What we have seen is the prevalence of chronic liver disease, and the data reported thus far is lower than we might expect. Only 7 of the 12 studies in a literature review from China reported the prevalence of chronic liver disease, and the range was far lower than we might expect, spanning between 2 and 11%. Among 5,700 COVID-19 infected patients in New York City, only 19 or 0.4% were diagnosed with cirrhosis. While obesity and diabetes were common in this population, it was not necessarily designated as non-alcoholic fatty liver disease, but we can presume that some of this existed. It raises the question, are patients with chronic liver disease or cirrhosis just doing a better job of sheltering in place? Are they aware that they have a chronic disease? So hand washing, mask wearing, and social distancing practices are much better than the general population. Perhaps. We also have to acknowledge that there could be some misclassification of current data, as the focus has been on COVID-19, registering patients with other comorbidities like viral hepatitis or non-alcoholic fatty liver disease may not be done as accurately. Next slide. In order to gain more information on COVID-19 and its impact on chronic liver disease, cirrhosis, and liver transplantation, we've developed a registry, and I've been fortunate enough to be a part of the Secure Cirrhosis Registry. We've partnered with colleagues in Oxford, UK, who run the COVID HEP registry. This is a combined international registry that has identical data entry forms. Requirements to enter patients into the registry are a laboratory-confirmed COVID-19 infection and a diagnosis of chronic liver disease, cirrhosis, or a prior liver transplant. Since we started this in late March, we now have 915 submissions from 34 countries. Within our cohort, NASH is the most common etiology of chronic liver disease, followed by alcohol-induced liver disease and viral hepatitis. We have a truly international representation. The United States, the UK, and China have submitted the greatest number of cases, but there are 10 countries with more than 10 submissions. Next slide. Data, back one slide, please. Data gleaned from this registry have shown an increase in the odds of mortality with cirrhosis severity. In our initial publication, we showed that with chronic liver disease without cirrhosis as our referent, Child-Pugh A patients had a numerical increase that was not statistically significant, but we did see a stepwise increase in the odds of mortality with Child-Pugh B and Child-Pugh C cirrhosis. Other independent risk factors for mortality include age and obesity, and this is consistent with the general population. Now that we're analyzing a much bigger slice of more than 750 patients with chronic liver disease and cirrhosis, we're seeing this trend continue with even a significant risk for Child-Pugh A patients as well. Next slide. Among our patients with cirrhosis, decompensation events are common. The frequency of these events increases with severity of underlying cirrhosis as measured by Child-Pugh classification. And what we've seen, GI symptoms defined both as nausea, vomiting, diarrhea, and defined as decompensation events are quite common in this population and may even be the presenting symptom without necessarily patients suffering from respiratory symptoms. Next slide. We also know that acute on chronic liver failure is deadly and infections can trigger acute on chronic liver failure. COVID-19 is no different. In terms of outcomes of patients with COVID-19 and acute on chronic liver failure, we see the increased stepwise mortality with rising ACLF scores. Next slide. So how do we care for our patients with chronic liver disease? Well, because we've got data that abnormal liver enzymes are common, abnormal liver enzymes need evaluation. I don't think that we can assume that our patient is having a flare of their hepatitis B or their autoimmune hepatitis. We do see a pattern of AST predominance over ALT. Could this be alcohol consumption? I think we do need to consider COVID-19 testing in these situations. As was pointed out earlier, there is no need to reduce immunosuppression for our patients with autoimmune hepatitis or in our transplant population for asymptomatic or COVID-19 negative patients. What we do need to do is continue to enforce social distancing, hand washing, mask wearing, and common sense clinical practices. In our efforts to keep our patients out of the hospital or out of the clinic where they may be exposed and perhaps safer at home, we have continued to expand our use of telephone visits and video visits. Other practices have helped as well too, like not needing to update labs solely for UNOS listing purposes. What we do need are more data and greater numbers and a better sense of the overall denominator of patients with COVID-19 to determine risk factors for outcome and also to determine the role of immunosuppression in the disease course. Next slide. We've seen, based on the map shown thus far, that COVID-19 is variable throughout the country, and it's been variable over time, and it's been variable throughout the world. It's going to have a heterogeneous impact on all of our hepatology practices, depending on geography, where initially we saw increased outbreaks on the West Coast and the Northeast. Now we're seeing an increased incidence in the South and the Southwest. This is all mediated by population density. Once a disease that we saw much more frequently in urban centers is now spreading to rural areas. And as there is a zeal for opening back up society and opening back up businesses, will we see a second wave of COVID infections? We need to acknowledge the limitations of our data thus far. Registries are potentially subject to selection bias, and single center data may not be generalizable to all patients in all centers. Thus, we have to continue to accumulate data and rely on expert opinion for this, and acknowledge that things will change. Our practice will evolve over time with more experience and better data. Next slide. As important as it is to focus on COVID-19 infections, we cannot lose sight of our patients with chronic liver disease who do not have a COVID-19 infection. We're seeing resource limitations for our patients' acute care needs. We are seeing disruptions in our chronic care practices when it comes to screening for varices or screening for hepatocellular carcinoma. And I think if we examine the four-wave paradigm of a pandemic, we all need to be aware of the potential fourth wave of post-pandemic trauma that has special implications for hepatologists. We're seeing increases in alcohol and substance abuse, and there can be increases in mental health problems with depression, anxiety, and post-traumatic stress disorder that can come with social isolation and the trauma involved with the pandemic. The pandemic is having an economic impact across the board, and this is true for healthcare as well too. Such an economic impact will have a special effect on public health initiatives, especially when it comes to viral hepatitis elimination and alcohol. Next slide. Finally, I'd like to acknowledge our partners who have helped make our registry possible. Within Secure Cirrhosis, I'd like to give a special thanks to Andrew Moon, who has really driven this project forward. And also thank our collaborators in Oxford. Tom, Gwill, Ellie, and Tamsin have been great collaborators and great people to work with. Next slide. And with that, I'll end my presentation and thank you for your attention.
Great, thank you for that excellent presentation. And next, I would like to introduce Olivia Cates from the University of Washington, who's going to give us some updated information on COVID-19 in liver transplant recipients.
Thank you very much, Dr. Verna. If we can go to the next slide. I have no financial disclosures. A big part, pardon me, Dr. Verna, can I have a little more?
Right.
A big part of why you're hearing from me today is my participation in the University of Washington COVID SOT registry. This project has been collecting electronic case reports of COVID-19 in recipients of all types of transplants since the beginning of March. And the data presented today are part of a larger data set that was extracted in May for analysis. I ask that you just consider these data preliminary. Next slide, please. As of May 13th, the registry contained complete initial and 28-day follow-up information for 73 liver transplant recipients from 23 states. 22% also have a kidney transplant. Next slide, please. The median age of patients is 62. 66% are male, which is fairly close to the proportion of liver transplant recipients that are men. But looking at race and ethnicity of reported cases in more detail, it does appear that Black and Hispanic patients are overrepresented in this population compared to their representation among liver transplant recipients in the United States, and even in New York State, which we saw was the largest contributor to the registry. Similar disparities have been seen in the general population with COVID-19 and are likely related to structural factors that put patients of color at higher risk for COVID-19 exposure. Although transplant patients may represent a relatively privileged subgroup, they don't appear to be protected from this effect. Next slide, please. The median time post-transplant is 5 years. 11% of patients were transplanted in the first 4 months of 2020. And these patients are on fairly standard immunosuppression. Just about 1/3 are on 3 drugs, 1/3 on 2, and another third on only 1 drug. There are 4 patients on no immunosuppression. Next slide. Comorbidities were common in this cohort, particularly hypertension, diabetes, obesity, and chronic kidney disease. While there were quite a few patients, over 20%, with none of these comorbidities, 34% have 3 or more. Next slide. I'll be brief here and say that the symptoms and other clinical findings at presentation are similar in SOT recipients in the general population. 40% of liver transplant recipients in our registry had any GI symptoms at presentation, but only 1 of these patients presented with isolated diarrhea. The rate of GI-only presentations in the overall cohort was a little higher, closer to 5%. Next slide. 64% of these patients were admitted for COVID-19 related illness, and another 11% were diagnosed while already in the hospital for another reason, in some cases the index hospitalization for their transplant. 33% of all patients were ultimately admitted to an ICU, 27% required mechanical ventilation, and 21% received vasopressors, suggesting a high rate of shock. But there are no reports of cardiomyopathy in these patients and no use of inotropes. Next slide. 21% of all liver transplant recipients in the registry died within 28 days of their COVID-19 diagnosis. And the mortality is unsurprisingly higher among hospitalized patients. There was 1 expected outpatient death in a patient already in home hospice care. Now these numbers appear very high, but I want to highlight that this is an observed all-cause mortality rate over a pretty long follow-up period in COVID terms for a selected patient population, patients who are ill enough to warrant testing in the early phases of the epidemic. While these numbers appear higher than estimates of population-level case fatality rates, for example, from the Johns Hopkins COVID tracker, they're actually not very different from similar observed all-cause mortality rates in the general population. The next slide. There are just some examples here. Each of these studies, like our own registry project, has data collection and analytical imperfections, but in general, I think it's reasonable to suggest that we should scrutinize our initial gut reaction to a case fatality rate above 20% in SOT. Next slide. The most common complication in our registry was AKI by far, and at a rate similar to the general population. Liver injury was actually uncommon and fairly modest, and only 2 patients experienced thrombosis, neither involving the hepatic vasculature. Next slide. We did see a high rate of confirmed and presumptive bacterial pneumonias, perhaps because of a higher index of suspicion for secondary infection in immunocompromised patients. There's only 1 report of invasive fungal infection in a liver transplant recipient with COVID-19 in our registry, but this has been reported elsewhere and in the general population. Next slide. And we saw a high rate of bloodstream infections, including polymicrobial bloodstream infections and multiple drug-resistant organisms. Compared to a study of all patients with COVID-19 in 1 New York hospital, this rate of bloodstream infections appears quite high. Next slide, please. And finally, this graphic shows repeat tests for all patients, not just liver transplant recipients, in the UW registry. Repeat testing may be biased toward patients with persistent symptoms or prolonged hospitalizations, but we see that many patients are shedding virus for at least 3 weeks and some for more than 6 weeks after diagnosis. Still, the average duration of shedding appears close to 20 days seen in the general population. Next slide. Brief published communications from other registries do show similar findings, with mortality over 20% in hospitalized patients. In the ALITA registry, it appeared that older age was predictive of mortality. Next slide. But what we still do not know, what are all of the risk factors for mortality? So far, there's some evidence from ALITA as well as from a cohort study in New York that age and comorbidities may play a role. So far, there's no evidence of a contribution from transplant-related factors like time since transplantation or degree of immunosuppression. Although SOT patients may have similar mortality to the general population, we do not know if there are unique mediators of mortality. For example, SOT patients appear to have very serious secondary infections. And finally, what is an optimal management strategy? Next slide. So from here, we'll be talking about treatment. This graphic shows all of the treatments used for patients in the UW registry, with reduction of immunosuppression and hydroxychloroquine being the most common. Of course, treatment strategies are going to change over time, and I think if we looked at a new cohort, we may see something completely different. Next slide. Looking in more detail at immunosuppression management, there is one small published clinical trial of cyclosporin-based immunosuppression versus reduction in immunosuppression for patients with COVID-19, and patients in the cyclosporin group did significantly better. It's not clear what aspect of the intervention, cyclosporin specifically, continuation of immunosuppression in general, or continuation of MMF specifically, or something else, might be responsible for this difference, and it's also not clear if these findings will be replicated. Next slide. And then I think we should also address steroids. A recent press release, and now I believe a preprint, reported very positive findings from the recovery trial of high-dose dexamethasone for patients with COVID-19. They report that dexamethasone significantly decreased mortality for patients requiring mechanical ventilation, and the benefit seems to be seen specifically when the drug is administered in patients with severe or later disease rather than earlier or more mild disease. Results from 2 studies of patients with inflammatory bowel disease showed a concerning association of baseline steroid use with increased infection and increased mortality, with a very high odds ratio adjusted for other baseline factors like disease severity. Considered together, these findings suggest that the timing or chronicity of steroid use will probably significantly modify their effect on patients with COVID-19. Next slide, please. Unfortunately, studies of treatments for COVID-19 often do not include many SOT patients. While it's likely reasonable to extrapolate a bit about treatment effectiveness, I did just want to call out some potentially important features that might be specific to our patients. For remdesivir, it may be difficult to deliver this drug to all of our patients, many of whom have chronic kidney disease, end-stage renal disease, and some of whom may have more pronounced baseline LFT abnormalities. Liver toxicity is a reported side effect, although it doesn't appear to be very common relative to placebo. For dexamethasone, transplant patients may experience drug-drug interactions, side effects that may be more problematic in the setting of pre-existing liver disease, or overlapping side effects with other medications. Next slide, please. And for tocilizumab, there are very serious safety concerns regarding liver toxicity, as well as infectious complications. Next slide, please. So in looking for a way forward, I would argue that SOT patients are similar to the general population with regard to known risk factors for infection, like race, and risk factors for mortality, like age and comorbidities, and also similar with regard to clinical presentation and some complications. Infectious complications may be an exception and may have more serious implications for SOT patients. It's still unclear what, if anything, to do about immunosuppression, either prior to infection or after diagnosis. But I think it's worth questioning the common approach of reducing immunosuppression for patients presenting with COVID-19, as recommended in the AASLD guidelines. And while we can probably extrapolate some treatment data to SOT, we'll need to think about toxicities that can have a special impact in our patients. Next slide. And as a parting comment, I think it's really great that we're considering patients with chronic liver disease and patients with liver transplants together in this discussion, because this gives us the best information to examine decisions about taking patients with end-stage liver disease and giving them liver transplants in the context of COVID-19. Next slide. I owe several thank yous, most of all to the UW registry team, especially Dr. LeMay and Dr. Fisher, and to our contributors, including some fellow presenters today. I'm really looking forward to their discussion. So thank you very much for letting me speak, and let's move on.
Great, thank you so much, Olivia. So it's now my pleasure to introduce Emily Blumberg to lead our panel discussion.
Great, thank you. We're going to start with a question, I think. But before starting, I just want to thank all of the speakers for really outstanding presentations. So I'd like to pose this question to the audience. For patients with urgent transplant indications, such as acute liver failure or MELD greater than 35, who are known to be SARS-CoV positive, but afebrile and without pulmonary manifestations, what would you do? Would you proceed with transplant? So the options are yes for acute liver failure, but not for MELD greater than 35. Yes, as long as the patient has a normal chest CT, or no, not until they're swab negative for the virus. So we're going to leave this to the audience to vote. And then I'm going to ask the panelists to comment on this as soon as we get your votes in. Okay. And you can see here that there's not an overwhelming majority for this vote, but most would prefer to wait till they're swab negative for the virus. So let me turn this to the panelists, and I don't know who wants to start with this, but Jean, would you be willing to start as the person who has to put the liver into that patient?
Yeah, I was hoping you wouldn't call on me. I think this is a tough decision. We just debated about transplanting a patient who had been negative on several swabs and then became positive again. We ended up holding off, but she was not acute liver failure MELD over 35. I mean, we're talking about people who have a survival probability of days, well, particularly the fulminates. We did transplant a child by mistake from a COVID positive living donor in the first week of the pandemic. Both mother and child probably had it. She developed COVID hepatitis and recovered. So I think that a young person with a normal chest CT and who was not expected to survive more than a few days from liver failure, I would support going ahead.
Great, thank you. Who else would like to answer this? Mike, you look like you're...
Yeah, I was just going to say, so I think that, first off, there isn't clear data on what to do in this kind of setting. And I think in the end, you always have to balance the risk of death of the patient from their underlying disease with the risk of progressive disease, plus the risk of infecting other people on the team, other patients that may be on the floor, and the like. That being said, I also think it's a little bit more complicated than are they positive or not. I think we are used to seeing these come up as results as positive or negative, but for most assays, there's ways to get a CT value, which is a relative indication of how much virus is in the patient. And so we know patients shed virus for a very long period of time. Liver transplantation, typically we aren't giving a lot of enhanced immunosuppression around the time of the transplant. Generally, they're not getting TAMPath and the like. So I think if you had someone who had virus close to the limit of detection, I would be a lot more comfortable than if you had a really low CT value, which correlates with high viral load, because they may be just becoming symptomatic maybe tomorrow or the next day. So that would be sort of my approach, is the balance on how badly they need it. So I think someone with fulminant hepatitis, you'd be pushed a little bit more, and then looking at how much potential virus was present in the patient.
Mike Shilsky, it looks like you're ready to say something.
Yeah, I think as we all do, we all want to be our best advocates for our patients, and certainly doing a transplant in somebody who's doomed to die otherwise is certainly beneficial for that one individual. But we're stuck with this still rare resource, and we have to use it best for all of our patients. And with unknown outcomes, and this sort of fits in the Dick Cheney unknown unknowns of what's going to happen to our patients, you know, the best utilization probably at this time, until we have medications that we know will effectively treat the virus, is probably not to transplant patients who are positive, as difficult that is.
John Bukavalis, do you think it matters if it's an adult or a child? You're muted.
Thank you. I'll go back to what Jean Amon said, is the kids, I think, generally do well with the COVID. There's the multi-system inflammatory syndrome, which is very rare. So I think that actually they've done well. That together with the potential for years of life saved and the absence of comorbidities, I think I would go ahead. And I think the comment that Michael made about cycle time is really important. And I think that if we can get that information, if the cycle time is the time for which the cycle is high, then I think that really pushes me forward.
Thank you. Sid, what's been the international experience? Can you tell us from from the registry for patients with cirrhosis?
The international experience of how patients with cirrhosis have done, or the international experience?
Like in terms of what people's likelihood of transplanting these patients? Do you have a sense of that from your registry data?
Yeah, it's not a discrete value that we've gotten from our registry data, but I think what we can say is that the data that are out there where patients have been transplanted with a COVID infection have not done particularly well. There are reports out of Europe, not necessarily livers, but other solid organ transplants that patients have died or remain ill in the hospital long after transplant. What we've seen in our registry of patients who are post-liver transplant who acquire COVID-19, their mortality is on par with the general population's mortality with COVID-19. We have a paper that we're about to submit for publication where we've got a cohort of non-transplant COVID infected patients, and it looks like they do about the same. So I think once you can get patients past the issue of transplant and their high immunosuppression, over the long term, these patients do about the same as anybody else.
Okay, thank you. And Olivia, I know in your registry that you actually categorized how far out people were from transplant. And if you think about the larger group and maybe the liver group as well, does time from transplant matter in terms of outcomes?
I don't think that we're observing any signal that either more recently transplanted patients or patients more remote from transplant are having differential outcomes. I actually have seen some publications proposing that patients who are more remote from transplant might be at the highest risk if they're accumulating more chronic medical conditions or worse organ function, but we didn't observe any difference.
Although the one thing I will say is, although there may not be differences in outcome, at least our experience, I think this is the experience in the overall registry, is that patients that are further out are more likely to potentially get infected. And again, our experience here, I think it's over 80% of the patients are out and pretty far out. And I think it's because patients that are in the first year are probably super diligent and careful. Someone that's several years out from their transplant probably forgets that they're an immunosuppressed transplant patient, or at least mentally wants to forget about that and is maybe a little less careful.
That's a good point. Betsy, do you want to share your experience in New York? You're at one of the centers that probably had among the largest transplant experiences, single center.
Yeah, I think I echo what's been said so far. In our data here at Columbia, across all the different organs, the time from transplant had no impact on the overall outcomes. And there was a huge spread in the time from transplant. We had several people that were infected within the first year, some of them within the transplant hospitalization. One baby that Jean already discussed that probably had it maybe even before the transplant. And then we have people that were 10, 15 years out. And it didn't seem like it had a big impact on their outcomes, maybe other than their age and their other comorbidities. And I think that's pretty clear across most of the data that's been reported so far.
Great, thanks. I'd like to switch gears a little and talk about donors and ask you all, we're going to start first with live donation, because some of the questions that have come up across the chat box have been whether or not we can ever accept live donors who are COVID positive, and if so, what are the criteria that they should meet to actually be an acceptable donor? So would like to take that one? Mike, you look like Mike Eisen. You
Sure.
look like you're lit up there.
So for most cases, living donation is a relatively elective procedure. They get scheduled at times that are convenient for the patient, for their families, for the surgical team, and so deferring transplant for a short period of time oftentimes is an option. May not be the case when you're dealing with a fulminant patient, particularly in the pediatric setting. But nonetheless, again, I think this goes back to what I said before with the deceased donor or the candidate, is that you have to look at the total picture. When were they diagnosed? How sick did they get? If someone was in the hospital and on a ventilator, for example, and they're still positive, they tend to shed virus for a longer period of time. And from some data that's will be published soon from the Netherlands, the ability to detect virus by culture in those patients extends out a little bit further. If they were truly asymptomatic and have never had symptoms and their CT values are at the limit of detection, I would probably say let's retest them in a week if the recipient can wait and try to get them to negative. And really only in, I think, dire settings would I even remotely consider the use of them.
Other thoughts?
Agree.
I think
Emily, I'm just, the one thing I was thinking about what Paul Farmer says about space, stuff, system, and staff. And it's a really good point, because I think if you're in a place that's surging and you have limited space, your staff are deployed, which is what we dealt with in New York. You don't have the ventilators, so you're not sure about your ventilator situation. That's a very different situation about the timing of the transplant compared to someone that may have been positive and it cleared, and you're in a low risk state. So I think if you compare New York City now compared to where it was in April, it's a different world, totally. And I think that impacts decision making. So I think you're not only looking at the patients themselves and the donor, you're looking at broadly at what's the system doing as well.
Okay, thanks. Olivia, you looked like you were about to say something too.
Thanks. Yeah, what I'm thinking about is the health and safety of our living donors. There was some evidence reported out of China that even patients with asymptomatic infection who were inadvertently operated on for another indication tended to have worse outcomes. And so I think that, we have a very serious duty to our living donors, and barely know why that's happening. If COVID-19 infection, in addition to respiratory illness, is a coagulopathic state, or if there's other organ dysfunction that we're not appreciating. So that's one reason that I would have a lot of hesitation to use COVID positive living donors for their own safety.
Great, thanks. Other thoughts?
One thing I'd like to add is, and I'm interested to hear what others think about this, is both for our donors and recipients, we've also had the scenario where swabs are not consistently positive or negative, or don't seem to be trending in the same direction consistently even if we're doing more quantified testing. And so we've definitely had recipients that have come in asymptomatic and were swabbed and were positive, and the next one's negative and the next one's positive. So I'm curious to see what people would think of that. So in a living donor scenario that's not an emergency, how many swabs do you need to be sure that you haven't had a false negative? And is there any other testing that you would do necessarily? Would you do a chest CT? Would you do more invasive testing, even in an asymptomatic person?
This is a great question, and I think it speaks to the issue of when you test a low risk population, you are going to get a certain number of false positives. And so I think one of the big issues when we start talking about testing live donors, and we've actually seen this in some of our transplant candidates who get an organ offer, who are completely well from a infection standpoint, and then wind up with that positive test. And so Mike Eisen, maybe you could talk a little bit about this issue of how do you know a test is real? How do you know how many tests you need that are, negative to proceed? I think that was a topic of great interest. And then I'd like to hear after you what others are doing practically in their own centers to try to grapple with this issue?
Yeah. So our approach here for all transplant patients, candidates, and potential donors that are positive, we require 2 nasal swabs to be negative. Our thought is this is consistent with CDC guidance for the clearance of patients. The benefit, optimally they would be 24 hours apart. If someone is having, as you described, of positive, negative, positive, that's not a false positive. That's someone that probably is at the limit of detection, and that's been well described with this infection. So, I think 2 negatives would be the critical thing if someone has a known positive, before you can be confident that they're negative. It becomes more of a challenge. We had one of our lung recipients who was in the hospital for a month and a half, went for an elective procedure and had a positive swab that, for a lot of reasons, was positive. We didn't think that was the case. She had a whole slew of negatives after that. So, a single positive with multiple negatives afterwards, then you can be more suspicious that it's a false positive. But I think if you get that plus negative, you're probably at the limit of detection.
Other thoughts? Has anybody sort of counseled their live donors in some way about this testing they're going to undergo and what they should do about it? Jean, it looks like you're...
Yeah, so I'd like to suggest that there's no circumstance under which a live donor should proceed until we're sure they're completely recovered from this disease. If a patient needs an urgent, it's not an issue in kidney because there's no emergency transplants in kidney. If a person needs an emergency liver transplant, that means they either have a high MELD or they're status 1. So they're going to get a deceased donor. So there's just no, in my view, there's no circumstance why we should expose a live donor to even the small risk. Whereas with the recipient, it's a different thing because we're balancing their own risk from the non-COVID health condition to the risk of COVID. I wanted to jump back to something that popped up, and maybe we're going to talk about it later. So at Columbia now that we're past the pandemic, the incidence of positive tests, now we test pretty much everybody who comes to the hospital at all times, and the overall positive rate now is down to 1% in presumably asymptomatic people, whereas when we first started testing, our positive rate was 50%. So the only other related thing is, I think the risk to the team of operating on a COVID positive patient is exceedingly low with proper protection. We haven't had anybody get sick on our teams now since the first couple weeks when we weren't wearing masks. So I think the risk for both nosocomial spread as well as a provider spread is really low if people are properly protected. That's just an opinion.
Other comments, thoughts? I'd like to transition then to the deceased donor population. Been a lot of questions about if anybody's aware of any deceased donor transmissions. Has anybody heard of any?
I don't think there's been any reported to date. There's been concerns about it, but none that have been reported.
Okay. So then, having said that, I'm going to ask a two-part question with deceased donors. One is, what is our optimal way to evaluate and test these donors? And number two, now that there's so much differential spread of COVID and it's sort of like a changing target, given the greater geographic sharing of livers now, how does that impact your decision-making and your recovery teams? So who would like to start with sort of evaluation of the deceased donor? What's the right evaluation? What would make you feel comfortable that that deceased donor is safe?
Well, obviously and as UNOS has put out in their documents, they prefer NAT testing and not some of the others, and certainly not antibody, which has a much false, negative rate compared to nucleotide-based testing. But, the problem with donors is you only get limited history sometimes. And you do, in the deceased donor world, do sometimes have good time to get imaging of the donor. So if there is any questionable history, fever or other symptoms that might fit within the CDC criteria, you can push for more advanced imaging. In, I guess, the most advanced cases, you might even push towards BAL, but that's, something that people don't prefer to do. To your point about moving teams around and recovering, and Jean perhaps can speak best to this as well, is it certainly being discouraged, and local recovery is preferred in that you do not transmit between zones of where you have differential incidents in the populations, either bringing, something, there have been transmissions from people going out in teams to other people, personnel working in other areas from the recovery team. So and it cuts both ways. So it's probably better to get the local recovery and transfer the organ if possible, but that takes a lot of trust and learning for all of us. And I think that's, where we have to go.
Jean, do you want to comment on the recovery team aspect?
Yeah, we travel far and wide, and we often use marginal organs. So we've been sending our team everywhere they're allowed to go. Every now and then they're not allowed to go. And in fact, we were recently prohibited from going to DC. They sent us a liver that turned out to be terrible and didn't work. So again, I'll go back to my thing. If our people are going places, they're wearing N95s with another mask over it. And I think they're going to be fine. And they're not taking viruses from New York to Texas anymore, probably the other way around. But Mike, you said there were recovery teams who had been infected from traveling to, I mean, it's not like you're going to a rally in Tulsa with no masks.
I think this is more in the early phase, John. I think you're right, probably with better protective gear and knowledge, people are less likely to transmit. But still, the less people moving around, and certainly we know people can be asymptomatic and still transmit. It's always a concern.
And I will say, I know, again, and this was early on, we had our team that went out and right after everyone had returned, one of the thoracic surgeons that was out on the recovery got sick on the way back, was tested and was COVID positive. And there were exposures that were evaluated during that setting. So it sidelined a bunch of our team and a couple of our fellows for a period of time. So.
Other thoughts, John?
Do you feel like, or I've asked people on the panel, do you feel like you owe a comment to the recipient if someone's coming from a high prevalence area? Does that count as a high risk transplant?
That's an interesting question about whether there's almost a special informed consent in that case, like we do with other increased risk organs. What do people think?
Well, I know our approach is we have added and I know this is being used at all the centers, at least here in Chicago, for all of our potential recipients, that there's now a tiny little paragraph that talks about the risk of COVID-19, not just from the donor, but also from the risk that we don't know everything yet about COVID-19 in the post-transplant period, and they may be at increased risk if they were to acquire it after the transplant as well.
Mike Shulsky, you looked like you wanted to say something about that.
Well, I mean, it technically hasn't been labeled as high risk by UNOS as yet, but, Mike raised a great point about, again, but how much, whatever you write, if somebody gets the transmission, they're going to still turn around and blame the transplant community. So, we can only do what we can do. And I think the best testing we put forth, the more careful we are in obtaining the histories and evaluating the whole donor, not just obviously looking only at your organ. You have to look for clues. It's hard.
Other thoughts about that? You know, I want to get to one other question in terms of testing, and I'm curious to see whether any of you look at serology in any of these patients at any time, and if you do, what do you use it for? I think there's now over 100 serology tests on the market, and we know that a bunch of them aren't any good, but there's certainly been a lot of concern in the OPO community. And I've heard actually maybe the New York OPO is actively looking at using serology. So I'm curious what you guys all think about that. All right, Mike Eisen.
I think there's no role for serology in organ transplantation. The patients can have a positive IgG while there's ongoing replication, so it doesn't help you in ruling out that they are potentially infectious. There is false negatives early on in the clinical disease, so it's not helping you in any way, shape, or form. Where it may be helpful is as we learn more about the long-term effects of COVID-19 on the organ, is that we may find that livers, for example, from patients that have recently recovered from COVID-19 have more liver damage and may have less long-term outcomes. But until we have that data, I'm not sure it's providing us any benefit to risk stratify the donor.
I wanted to switch gears one more time. I think we're almost out of time, but I did want to ask a question of John Bukavalis, and that is in terms of the pediatric experience. You know, there's been a lot of questions about why is the pediatric experience different? And is it different in kids with liver disease compared to other children who may have COVID-19?
I don't think our post-transplant patients, and even the ones that were pre-transplant, I don't think we're seeing much different from the general population. But certainly the multi-system inflammatory syndrome is different. And a lot of those kids don't have respiratory symptoms. They have almost a high HLH type picture. And that is distinctly different, but that's a very small subpopulation. I don't think we know the answer yet.
Mm-hmm. So are you seeing very little COVID-19 in your pediatric patients?
Well, we saw in April, we saw plenty, but we're not seeing it. It's like what John and Betsy said. I think it's not there now in the community, but in April we saw a lot. Our units were filled both with transplant patients and with non-transplant patients with COVID.
Better herd immunity in New York. Well, I think that's our cue to wrap this discussion up. I want to thank all of the speakers and the panelists. I think that was a really informative discussion and great talks, and I think we all learned a lot from it. I'm going to push some resources, both from AASLD and on my part from the AST. I think all the societies have really worked hard to provide a lot of resources for all of you. And I know everybody's working hard to keep updating these so that what you're looking at is hopefully the most current things that we have to offer. So with that, I'd like to thank you all for attending and thank everybody for really what I think was a highly informative and such a well-spoken webinar. So thanks and have a great evening, everybody.
Thank you.
Thank you.
All right, thank you.
Thanks.